Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against the Radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
All right, welcome everybody. It's time to kick off on another MRI Pro webinar session. From wherever you are joining around the world, thank you very much for joining us. My name is Jeremy Grummett. I'm a urologist here in Melbourne, Associate Professor at Monash University, and also one of the co-founders of MRI Pro. This webinar is brought to you by MRI Pro. And I guess just an explanation of what it is. Obviously, we do free webinars. In fact, this is our 10th webinar now. So we've been racking them up. But in addition to that, it's an online training program where you can subscribe to 300 cases. And our purpose is to train up radiologists, urologists, and trainees anywhere around the world that you may be, without you having to practice on real life patients. So as you go through the 300 cases, you get to instant feedback, as you'll see during this webinar as well, how we do that. Now, something that's exciting and new is in order to try and increase accessibility to the 300 cases, we've just recently introduced a monthly subscription option in addition to our annual subscription, which is $120 per month. So you can still access the full 300 cases, and if you happen to get through them in a much shorter period of time, then of course you can save a lot of money by doing that. So just trying to increase accessibility to the program. I'd like to thank Movember, who is one of our major partners, who continue to support us. And I'd also like to introduce our very esteemed panel members. So first of all, we have Dr. Clare Allen, a radiologist who's an expert in prostate MRI, coming to us from University College London. Clare, welcome.
Thank you very much. Thank you very much for inviting me to come. Looking forward to this morning. Morning for us.
Yeah, that's right. So it's getting into early evening here in Melbourne, but 8 o'clock in London. And Clare, you have obviously been highly involved with prostate MRI education over the last few years as well.
Yeah, I did my first dynamic prostate MRI in about 1995. So I must admit, I'm pretty long in the tooth now in terms of the number of MRs. And yeah, so we've been doing biparametric, because obviously we didn't have diffusion in the early days, but and multiparametric MRI in earnest since about the early 2000s. So I think we started to do our first pre-biopsy MRI in about 2003. So wow. UCH has had a long history of doing the pre-biopsy MRI. Yeah.
Oh, that's fantastic. Well, we look forward to hearing your experience as we go through these cases today. And we're also joined by Dr. Veeru Kasivisvanathan. Veeru, whose name I'm sure is also very familiar to this audience, as the first author of the Precision study. I'm still not sure how you managed to herd all those cats, Veeru, to do that study. Welcome.
Thank you. Pleasure to be here.
So thanks for joining us as well, again from University College. Veeru, what's your latest? I know you've probably got about 10 irons in the fire, but is there any particular research project that you would like to mention briefly?
Yeah, so we're running a study called PRIME, which is looking at whether biparametric MRI is non-inferior to multiparametric MRI in the diagnosis of clinically significant cancer. It's looking to see the value of the contrast sequence. And really, we're looking at some of the advantages and disadvantages of potentially including it. We know that from the guidelines, MRI is being recommended more and more upfront to have capacity to deliver a service. A shorter, quicker scan might be advantageous, but we want to see in a fair way, if we drop that contrast sequence, what are we missing out on? And I think from the Precision study, the thing that we learnt from reviewing the scans was that the contrast sequence is probably the least well done sequence out of all of them.
Yeah.
And In order to evaluate it fairly, you need to use a scoring system that allows you to give contrast a fair play. So we're going to try and do that in the PRIME study, which is an international multi-center study in 500 men.
Yeah, it sounds fantastic. And you're actually planning to come to Melbourne for a fellowship next year, I believe.
Yeah, so that's the plan. So we'll be hopefully opening up some Australian centres, part of a Prostate Cancer UK aim to get an Australian network, which you can deliver some collaborative studies in. And I'll be doing a bit of clinical work as well at Peter MacCallum Cancer Centre. Fantastic.
Are you confident that you're going to be able to enter Australia at this rate?
I'm not confident at all, but we'll see how it goes.
Good on you. I might get back to you in just a moment, Veeru, so you can tell us about your upcoming workshop, but I'll just quickly introduce our regular panelists. So once again, we have Associate Professor Richard O'Sullivan joining us, who's our local radiologist and expert in prostate MRI. Hi, Richard.
Hello all, thanks for having me. You know, I'm a MR radiologist. I do other things apart from prostate MR, and we run everything we do at no endorectal call and 3T MRI on 4 different locations. We do about 2,500 prostate MR scans a year.
Thanks, Richard. Now, we won't be seeing Richard's face today because he's going to be showing us all of the MRI images. And we've also got Dr. Andrew Ryan, who's a specialist uropathologist who works at Tissue Path, which is a boutique pathology service specialising in prostate cancer, as well as other cancers. Andrew, welcome.
Thank you. Thanks for having me, Jeremy.
No, just fantastic. And I also love the way I think that what we've got with MRI Pro and in terms of the caseload is beautifully complementary to various workshops that are being presented, because you need to get that hands-on teaching, which is what you guys are going to be providing. And then I think a lot of people then need to go off and then just practice to get used to looking at just so many cases, and that's where MRI Pro can be pretty helpful as well. Veeru's just entered that link in the chat there, so please go and check that out and sign up. All right, so yet using the chat or the Q&A function, please don't forget about that as we go through these cases. We're going to have a look at 3 cases. And we are also recording this session. We post all of our webinars freely online several days after we've actually done the webinar. So if you've got colleagues who can't make it today or you can't stay for the whole session, please be aware of that availability. Okay, I think we should get stuck into the cases. Richard, are you happy to take over the screen? And while you're doing that, I might get going with setting up the clinical picture. All right, now the first one hopefully will be a fairly easy one. I think people might agree, just to get the ball rolling. So this patient was a 65-year-old man who presented with a slightly elevated PSA 5.5. We repeated it as per usual about a month or so later, and it came back actually slightly lower at 4.6. And now the interesting thing, we routinely, when we're repeating a PSA, use the free to total PSA ratio, or almost routinely, certainly very commonly in our own practice. Before we get to these MRIs, Richard, just perhaps a quick question for Veeru. In your practice, in your centre, are you using any additional markers like % free PSA in addition to just total PSA, or any other markers, or just going straight to MRI with an elevated PSA?
So typically the community doctor, the GP, will refer the patient with a PSA and an MSU, so a midstream urine microscopy that's negative, and they won't typically do a free to total ratio. So it would be something that we'd have to request. Typically we don't request it. Other things that we take into consideration are things like PSA density, but then you need the volume. But because MRI is approved pre-biopsy as per NICE guidelines, those men will usually go to get an MRI pretty early on.
Terrific. All right, thank you. So speaking of PSA density, as you'll see in a moment, based on the MRI, it came back at around 15%. Now, one other quick point before we actually talk about the imaging itself, this patient also had a pretty obvious nodule on rectal examination on the left-hand side. Now, another question, quick one for you, Veeru. If a patient does have an obvious palpable nodule, do you still get an MRI always or at all?
Yes. If the patient is of an age where treatment would be considered active treatment, I think an MRI would give you lots of information and that a digital rectal examination wouldn't. Your DRE finding, often it's done by your community practitioner rather than the urologist, so it's in the referral letter. So that's one aspect. The second thing, what is the test performance of a digital rectal examination compared to an MRI? I think probably not comparable. It is very useful pre-operatively when I do a radical prostatectomy and I'm making decisions on nerve sparing when they're under anesthetic. I think it's a bit more useful then. Otherwise, an MRI will give you information on the contralateral side, the anterior part of the gland, areas that your digital rectal examination may not.
Fantastic. All right, Richard, would you like to take us through the MRI that we got as a result of this man's elevated PSA and abnormal rectal exam?
Okay, so we have a Siemens Skyra. We use a body coil only, no endorectal coil. We use a sagittal, axial and coronal T2 image. And we also use an axial and a sagittal diffusion imaging with a calculated B value of 1400. They're the pictures on the right-hand side of the screen. This is the post-contrast images, which we use the wash-in phase. So it's the early parts of the contrast amalgamated together and put on a background of a T2 image. So what we might do is we might make life a little bit easier. If we just, I'll just link the ones that we use the most of. So as we go from base to apex, seminal vesicles here, transition zone here, which is does demonstrate restricted diffusion. Central zone, transition zone here, and then peripheral zone. And as we get towards the mid-prostate, you'll see there's an area of decreasing intensity in the posterolateral and posteromedial peripheral zone on the left, which does demonstrate restricted diffusion. It's dark on the ADC and bright on the high B value diffusion imaging. And you can see that extends all the way to the apex, extending anteriorly to the apex here as well. This is a prostate. The prostate volume here is 30 cc, and I've got that measured over 2.7 centimeters. So I've called that a Pyrotes 5 lesion, dark on the ADC, bright on the high B value diffusion imaging. It abuts the capsule over about 2 centimeters, and there is some capsular irregularity in the left mid prostate, which is suspicious for extracapsular extension. We hardly ever see a extracapsular mass, so it's only in very advanced cancer. If we go, we also see we look at the same pictures on the sagittal diffusion imaging. We can see, if we link the two of those together, we can appreciate here there's a low on ADC in the apex, high on the high B value diffusion imaging, which extends superiorly to about the mid-prostate. It is slightly more extensive than that when you look at the DCE. It probably goes close to the, it goes almost to the base and extends to the apex on the DCE with focal contrast enhancement.
Terrific. Richard, thank you. Claire, I would love to, perhaps Richard, if you could keep the images up for a bit. I'd love to get your thoughts on what you do the same or similarly, what you do differently in terms of, for example, just in the beginning, is this how you acquire your prostate MRIs in the way that Richard's described?
Thank you. So we acquire them reasonably similarly, and I think most people we've looked at scans across the world now, thanks to Veeru and the PRIME study. Most people acquire their T2 pretty similarly, and in 3 planes, and usually the T2 is done really well, and these are really high quality T2 images. We can see all of the structures that we need to see. For time reasons, we haven't done sagittal diffusions, and I think you're probably the only unit that we've seen that do So it'd be really interesting, you know, to hear sort of Richard's view on the sagittal. And I know it's like all things, when you start doing sequences, you realize how good they are. For us, probably we wouldn't have time to add that. We do an acquired long B as well as just the calculated, which I think you've got here. We quite like the acquired long B. I know there's lots of data to say that you don't need to do it, but we found that it can be very helpful. And I think the other thing that we do is we tend to look at the base GAD images rather than the maps. So we have a stack where you can scroll through in time. So a sort of 4D, if you like, image where you have all the scans together. I'm sure you can do that on your system. And we found that quite useful to pick up the early enhancement. I must admit, I like to see the gadolinium itself, and probably looking at this, it may well be that lesion actually does cross the posterior midline into the right side, I would think, on this. So most of what we do is the same. I think the big difference is probably the diffusion.
Yeah, I kind of think MR is an imperfect test. And it's a matter of building confidence and to close the gaps. And sometimes the things that we miss are actually at the apex. And we see the apex a lot better. The central zone can be confusing, and I think it's a bit less confusing at the base on diffusion. So the more chance to increase your confidence about seeing the lesion, the better chance you have of making the diagnosis, is how I see it. I think we do more time. It takes us about 40 minutes. It's quite a long scan.
Yeah, I think that's our, I mean, we got somebody in to take a look at our scans to try and increase the just the quality just overall, and they wanted to add a couple of minutes to the sequences overall, and we, you know, our radiographers threw their hands up in horror. So you know, we, like everyone else, is really tight for time. So I guess I would prefer, if there was a time issue, for them to repeat one of the really gold sequences, so like the T2, if there was for any reason patient movement or there was an issue with it, rather than having to plow through many more. So I think it's variable, and I think you're lucky you've got lots of time. Although we've got lots of MR scanners, we've got lots of other people who want to use them as well.
We've got a comment from Declan Murphy from Peter McCallum here in Melbourne, who says, "We love the sagittal views for surgical planning. It's a fantastic roadmap to the bladder neck." And Richard, you've also mentioned sometimes it can be pretty useful. In fact, we've got a case later up which we might sort of demonstrate the utility in the sagittal plane. But what do you think the time difference would be in terms of?
So my comments were really for the sagittal diffusions rather than the T2s, which I think are really essential for our planning. I don't think we could do them without our sagittal T2s. So I totally agree with that.
Right. But what might be the time difference in terms of acquisition in adding that? In
adding the sagittal diffusion?
Yeah.
So it's probably going to be about 6 minutes.
Okay.
It's not that long. It's probably three to four.
Yeah, okay.
But
Six
they just add one, just add one, just add one.
Yeah.
They do tend to multiply. But the text complain about everything, really.
Claire, a question for you regarding extra prostatic extension. You know, this is obviously a pretty decent lesion that we're dealing with here. In your experience, how well does the appearance of extra prostatic extension on MRI correlate with reality, or what we see on histology?
So when I think that when we're confident that we can see it, then we're usually right. The problem is that the histologists, the pathologists, can get down to 1 to 2 cells, and we're never going to see that. So in terms of, can we see all of the extraprostatic extension? Absolutely not. And we'll never be able to see the microscopic. We may be able to have a worry that it would be there based on other sort of patient factors, Gleason grade, volume of tumor. For us, I think the most important thing is we're using where the tumor is for planning. So in a way, it doesn't really matter if there's a bit of extra prostatic extension that we can't see, as long as we've mapped where the tumor is, both for the surgeons and for the focal treatments, because they know where the capsule, if there is any breach or if there is any microscopic tumor, that is where it will be. And obviously now with techniques like NeuroSafe, where you can take frozen sections during surgery, it's important for us to say where we feel it might be, even if we haven't physically been able to show it on an image. So, you know, the usual things that we would see is length of capsular abutment, a capsular bulge. Obviously, if we see direct infiltration, then that's a very likely sign that there's extra prostatic extension. But I think, you know, it's a matter for us to work as a team, in that the radiologist doesn't work in isolation, and that we certainly at UCH, and I'm sure in your institution as well, we meet together and discuss the case in the round with all of the information, and we make a decision whether or not that capsule's likely to need to be spared, can it be spared, or whether or not, certainly surgically, you know, your nerve spur will have to go wide. And I think, you know, we shouldn't think that we need to work in isolation as radiologists, and we should make sure that we're part of a team. And I think certainly your data set, where you're getting feedback on your extracapsular extension, will make radiologists much better at predicting it. But, you know, we're never going to see small amounts of tumor that the pathologist can see.
Yeah, yeah. Look, I'd really like to echo that comment. I think, you know, especially for people who are perhaps starting out to do prostate MRI, I think there's perhaps nothing more important than having that team of dedicated, interested people who are urologists, radiologists, and pathologists. That's how we started many years ago. I'm sure very similar to you, Clare and Veeru. And it's just been invaluable, you know, the learning that we've had from the very beginning, and just having that instant feedback through those multidisciplinary teams, I think is wonderful. Now, we better get onto the biopsy, because I'm mindful that time's getting away from us. Before we do that, though, a quick question for you, Veeru, that's come in through the chat is relating to this particular case. If your DRE is abnormal, but the MRI is negative, and you've got a low PSA density, would you still biopsy?
I think it depends on how abnormal you think it is.
Yeah.
You can consider it in the totality of factors, counsel the patient and say, based on your MRI and your PSA density, you have a low chance of having cancer. There is this abnormal feeling on your prostate, and you could offer them a biopsy if they were so inclined. I think our tendency has been the DRE is typically initially done by the community doctor, so we would maybe repeat it ourselves and see what we find. And if there is something still strongly suspicious, then yeah, we would counsel the patient for that possibility and see if they wanted it. If they didn't want it, you know, PSA monitoring is a reasonable option as well.
Could I just add something there? I think as radiologists, we are always looking at the clinical details. And one of the things that I look at really carefully, if I do think the MRI is negative, is some reason why they may have felt the nodule. So it may be that there's asymmetric transition zone. Sometimes there are transition zone nodules in the peripheral zone, which will be palpable. There may be calcification in the prostate. There may be periprostatic abnormalities that may account for the DRE findings. So I would try and put in the report some relevant negatives if I felt the scan was negative, but yet there was a DRE abnormality.
Yeah, terrific.
Yes, I would always say, if the request says apical nodule, I will say in the report there is nothing there, or there is something there. I will address that issue.
Right.
Yes.
I think the only other point I think might be worth making is that, again, if you're new to prostate MRI, or if your centre is, or your radiologist is, then if you are in any doubt, then you did proceed to a biopsy, well then that is not only going to keep you feeling safe, I guess, and reassured on the result, but also will provide that feedback to your radiologist, particularly in the early days. Now, Andrew, have you got the biopsy result?
I do.
He had a transperineal biopsy with targeted and template.
I've been waiting with bated breath. So for presentation, we got our macroscopic explaining the core lengths, microscopic here with site tumor involvement, or tumor grade, sorry, and tumor involvement. And so for this gentleman, corresponding to that MRI lesion, left anterior, left mid, and left posterior all involved with extensive up to 10 millimeters, and then in the left, your target biopsies up to 13 millimeters. And then some lower grade disease on the right hand side.
Okay, thank you. Now, question for you, Veeru. In terms of biopsies, is it the urologists who do the biopsies in your centre?
Mainly the urologists, but we do have the radiologists doing some as well.
Okay, and I guess just briefly, how do you do it?
So we do transperineal, targeted plus or minus systematic biopsies. We don't use fusion software. We've developed an in-house fusion software over the years with a trial we've been running, but we find with visually registered good transperineal biopsy, we get relatively good detection rates. So we're happy to stick with that. You know, choices for how we do the biopsy in terms of systematic or not, I think we can make it on a case-by-case basis.
Terrific, thank you. Local anaesthetic or general or sedation?
So our lists have a mixture of both. So when we book a patient for a biopsy, if it's a biopsy we're planning, we offer them either local anaesthetic or sedation. If it's a one-stop patient, i.e. they are referred by the GP with a raised PSA, they come in, the first contact is an MRI. They see a specialist nurse 2 hours after the MRI. They discuss the scan results with them. And if they need a biopsy and have capacity on the list on the same day, which is down the corridor, they have an LA biopsy the same day.
Wow, okay. And one of the questions that, you know, one of our colleagues, Roberto Miano, asked on Twitter a few months ago was the number of cores that we take in targets and so forth. So if you've got a large target like this one is pretty obvious on MRI, how many cores would you typically take? And I guess the second sort of follow-up to that is, would you do more cores for a small target that might be harder to accurately hit?
Yeah, so I think there is data on this. So I think between 4 and 6 cores for an MRI lesion is reasonable. I think the studies have quite clearly showed, there's a paper by Liu and J. Urol, 1 and 2 cores are not sufficient. And there are quite a few studies using 1 or 2 cores. There are targeting errors. We know the MRI, the cancer is slightly bigger than the MRI lesion as well. So 4 to 6 cores is what I typically do. With respect to the size of the lesion, when you look at the studies showing what the predictors of significant cancer are by targeted biopsy, size of the lesion and size of the prostate are usually significant predictors. So it does make sense if you've got a smaller lesion in a large prostate, which is going to be harder to target, to just be a bit more cautious and maybe take 1 or 2 more cores. So maybe I'd go in the upper end of maybe 5 or 6 cores rather than 4.
Yep. Yeah, I agree entirely. And that's what we would do as well. Andrew?
Can I just have a comment on that?
Please.
So I think the other thing is, I mean, I take quite a few prostate biopsies myself as a card-carrying uroradiologist, and I think sometimes it depends actually what sort of core you get too. So you know, when you're sampling and you're getting really nice cores that are hanging together, you can often tell if you've got a tumor core as well. Just by looking at the sample, you can tell that it's tumor. It hangs together, it sinks quickly in the pot, and so I think sometimes you may need to take more if you get a lot of fragmented or it's tricky and you're obviously not getting very good tissue samples. We haven't really addressed, and Veeru might like to do that, whether or not you should sample the other side or another lesion. And again, I think that's on a case-by-case basis, but we see a lot of patients who come to us for focal treatment, and we often have to repeat the biopsies because equivocal lesions or areas of possible tumor on the opposite side haven't been sampled because of a large lesion on the other side. So I think in these days of making sure that you offer patients personalized treatments, some of which may include focal treatments, it's important to make sure that the biopsy strategy, I guess, is agreed with the patient beforehand. But Veeru, you might have something more to say about that.
Yeah, so I think the decision for systematic biopsies is a controversial one. You've got different schools of thoughts, and I think it does depend on the patient. So if you've got a patient with a prior negative biopsy who's had good peripheral zone sampling previously, there's more of a rationale to just do a targeted biopsy this time in the presence of an MRI lesion. If you've got a patient who's biopsy naive, then I think for treatment planning decisions, so for example, if you're trying to start a focal program, if you're thinking about the contralateral side and nerve sparing decisions, even radiotherapy for your dosimetry planning, those kinds of things may influence whether or not you do the systematic biopsy. I think in reality, it depends on how good your MR is and how good your targeted biopsies are. And for you to make the decision to drop systematic biopsy, the centre would have had to have gone through a process by which all patients get MRs, pre-biopsy, targeted biopsy, and template biopsies. And over the years, when you figure out how good those things are, you can then decide whether or not to drop some systematic biopsy. So, for example, at UCL, we started off with pretty detailed biopsies. And there was a paper we published in 2013 in JEURA where we first investigated targeted biopsies. And the sampling density then was about 1 to 2 biopsies for every 2 mils of prostate, pretty detailed.
Yeah.
We kind of reduced the density over the years. We go down to a 20 zone modified Barzell. And now I think if you're going to do some contralateral biopsies or systematic biopsies, I think focusing on the peripheral zone is a reasonable strategy, and it doesn't need to be as detailed as that. And I think the morbidity from quite detailed biopsies is something that we saw in some of our previous studies, like PROMISE and PICTURE. So I don't think you need to do detailed 5mm transperineal template biopsies, but some contralateral peripheral zone biopsies in the same sitting is a reasonable option. I don't think there's a right answer, but I think if you know your MR and targeted biopsies are good, there's more of a rationale for you to drop some of those systematic biopsies.
Yeah, I agree with you, and in fact, Mark Emmerdon obviously has his own views on this as well, who's been a panelist on a previous webinar. I think from my perspective, if you think that the patient may be a candidate for focal therapy, then my preference is to do the template biopsies as well, for that additional reassurance that you're not missing anything. We'll come to that in a moment with one of the later cases. I think Mark, if I remember correctly, was basically saying that, at least in his experience, he prefers not to do the template biopsy and really basically trust in the MRI findings. Anyway, we can come back to that with one of the later cases. Andrew, if we move on to the prostatectomy, so based on the biopsy findings, this patient had a robotic prostatectomy, and Andrew will show us. If you could just explain, obviously, what.
Yeah. So these are scanned images of the actual histological sections, and at the time of reporting the case, we mark out the tumour foci on the slides, and then they're subsequently coloured in on a digital image of those scanned slides. So the image here, the orange, is the index tumour, as allocated as the highest grade tumour, while the black images are smaller foci of lower grade Gleason grade tumour. So the large lesion here corresponds with our MRI, involving large amounts of the left hemisphere or left lobe of the prostate. The yellow is areas of extra prostatic extension. So interestingly, it doesn't have it over in that posterolateral angle, maybe where the bulk of the tumour and the abutment was, but it was more anterior, with a small positive margin allocated as red. So this was a 3+4 lesion. Sorry, I should be able to progress. There we go. 3+4, 20% in the index lesion, whereas those smaller foci on the right-hand side were 3+3.
Just look at the extra prostatic extension, where it says that the radial extension. Just go back to the other side.
Yep.
0.6 centimeters in the radial dimension. That's what is commonly we see, I think, and we can't see that. We'll never see that.
Yeah, that's right. That's what you were saying earlier, isn't it, Claire?
Yeah, and I think surgically, I mean, certainly our surgeons, they just want us to outline where the tumour abuts the capsule. And we actually have a planning meeting where, again, as a sort of team-based approach, where we sit and every single patient who comes for a radical prostatectomy has their images reviewed with the biopsy, and we make a plan prior to surgery as to what sort of surgery they're going to have, what approach to use, what sort of nerve spare to do, and whether or not they're suitable for a sort of neurosafe frozen section type option. If they want to have a bilateral tight nerve spare. But I agree, this sort of extracapsular disease we might predict is there, but I'm surprised though, looking at that MR, that there wasn't some where you could see that little focal bulge though.
Wasn't particularly, like, these are always hard to, sorry, go back to here. These are always hard, especially, you know, we're saying its radial extent is 0.6 millimeters, but when there's a positive margin, we're actually, like, that's what we're seeing. But because the tumor extends on, we never know whether or not it's the radial extent is actually a little bit more than that. But look, that's hard because, you know, Richard's always said about this, you know, the circumferential extent of capsular abutment, and there's really quite extensive. So where would you, you know, like, it's a bit random that it's actually just in one site.
Yes.
Yeah.
Andrew, question for you just regarding that. If you keep that slide up, or actually the verbal report might even be better. So you've said this is a grade group 2, because there's only 20% Gleason pattern 4.
Yes.
But it's a big tumor.
Yes.
You know, and so there's a fair volume of pattern 4, even though it's secondary to pattern 3.
Yes.
So I guess, you know, we know that generally speaking, Gleason pattern 3 is pretty innocuous. My question is, I suppose, why not just report on the lengths of Gleason pattern 4 or 5, as the case may be, rather than the way we do it?
Well, some have proposed that we shouldn't even be calling 3+3 cancer.
That's right.
For that reason. But look, you know, I guess, like, just thinking on my feet here, if you had a lesion this large and only really reported on the pattern 4, then you are underreporting quite a, you know, like, another significant component of what this tumor is, and that's volume. And so when we go forward, you know, like, one of the reasons why this man may have a potential outcome is that he had a large tumor. And if I just report the percentage pattern 4, even though that's important in itself, the volume of the actual tumor is also significant.
So we saw, you know, pretty decent volume on the biopsy cause, even though there was a preponderance of pattern 3. Veeru, a question for you, just going back a step before this patient had a radical prostatectomy. If you saw that the biopsy was grade group 2, but it was quite large on the imaging as it was, would you stage that patient with any further imaging?
Yeah, so, I mean, we probably typically wouldn't actually do a staging scan. NICE guidelines wouldn't recommend that. Other areas which are a bit grayer are if you think there's some extracapsular spread, in which case, if their PSA is a bit higher, you might consider doing a staging scan. But I think typically this patient wouldn't have had a staging scan in the UK. And
when you say staging scan, what modality are you talking about?
Yeah, good question. So NICE guidelines recommend a bone scan. We know from many studies, like, you know, the one from Australia, the Pro-PSMA study, that your PSMA PET CT is superior in detecting METs. But I think the evidence for that in the UK hasn't been enough to convince them to change the guidelines yet. I think part of that is related to whether or not these extra METs that you find, whether treating them makes a difference to the longer term outcome of the patient. And whether, you know, for years we've been using bone scan and probably been performing radical treatment on patients with these micrometastases, and a lot of them have done pretty well. So I think the jury's out there on the long-term outcomes, but for sure, the PSMA PET is better at identifying METs. And when we can use it, we do. We accept we're in a tertiary referral center, and the ability for us to do that is a bit better, but even we get a bit of kickback from ordering too many. So it's a mixture. I guess it depends on the features of the disease and how high risk the patient is. And if they're really high risk, then yeah, we may be getting a PSMA PET rather than a bone scan.
So just to pick up on one of your points there, and being devil's advocate, you're right. We don't know what the outcomes are if we do use PSMA PET, but isn't the same true for MRI, which is already now in the guidelines?
Yeah, you made a really valid point, and there aren't any long-term outcomes related to whether the use of MRI would improve the outcomes of your patients. It's one of those things that it creeps into practice, and I think you can see the clear advantages of using the modality, and it's probably the same with PSMA PET. Sometimes it's hard to provide that evidence. Prostate cancer outcomes, you need a long time to be able to show a benefit. But we've got probably more than 10 years of good data now. So for sure, there is a desire to do those studies and show whether or not your MRI score, which in the shorter term is your strongest predictor of significant cancer, whether it's also your strongest predictor of longer term outcome.
Yeah. All right, now time's getting away. So why don't we move on to case 2, Richard, if you are happy to get that up. I'll just finish off by telling you that this patient, case 1, their initial post-op PSA was 0.06, which might make you a little bit worried that he was going to have a recurrence, but 2 years on, it's 0.07, essentially the same. So he's had no further treatment and continues to have PSA monitoring. He's not wearing pads and is achieving intercourse with the help of a PDE5 inhibitor. Okay, Richard, case 2, please.
So the one we've just seen, case 1, that's the easy one. I wish they were all as easy as that, but they're not. This is case 2. Prostate volume is 40 cc. Again, I'll just link the. So again, we've got the sagittals, the 3-plane T2s, the 2-plane diffusion, and the colour.
Sorry, Richard, I've jumped the gun. Let me just give you a quick intro from a clinical perspective. 63-year-old, PSA only 3.7, but 4.7 4 months later. PSA free to total ratio 21%. PSA density only 12%. And rectal examination was benign, but a positive family history with his father having had prostate cancer. So back to you.
Okay, I'm just busy linking these 3. So it's a 40 cc prostate. As we go from base to apex, there's a hypertrophic median lobe, and there's not a lot to see on the T2s, I think. The most obvious abnormality is on the ADC and the high B-value diffusion imaging in the bottom 2 slides. And you can see there's an area, or what I call asymmetric restricted diffusion in the transition zone. The transition zone is the hard area for us, I think. And it's the ADC measures on our system measures about 600. If we look at the, so if I look at that on the T2, it basically corresponds to this one here, which is relatively well defined. And if we look on the sagittals, it probably corresponds to one of these, also relatively well defined. And if we look on the high B value in the sagittal, it's slightly more extensive and has a bilobed appearance. These are the hard ones for us, I think. It's confined to the transition zone. It's not, for me to say it's a PIRADS 2, it's got to be very well defined margin on both studies, on at least 2 out of the 3 planes of the T2. Hopefully it should be heterogeneous centrally within that to be called definitely a PIRADS 2. So this is almost a PIRADS 2, but I'm very nervous about asymmetric restricted diffusion in the diffusion in the transition zone. So I would call this a PIRADS 3 based on that.
Yep. So you, as you say, Richard, this is in the transition zone.
Yep.
Claire, what do you think about what we're seeing here, and would you agree with calling it that? And also, do you use PIRADS or like it?
Oh, I thought you were going to ask me that, Chestnut. Yeah, no, I agree with everything that's just been said. I think some of the transition zone lesions are really difficult, and particularly these ones that we sort of, Tristan Barrett in Cambridge has called the look at me lesions. You look at the diffusion, and it's usually the sequence we go to first and last to make sure that you've not missed anything. And when these pop up like this and you can see them so clearly, you get really worried that it is something of note. But I think the T2 is really helpful here. I agree with you to look at it in 3 planes, because often you won't see the encapsulation on the axial plane, but you may well see it on the coronal or sagittal that gives you that confidence. So I think location is also really helpful, and usually lesions that sit in the posterior part of the transition zone are usually not tumours, even though they might look like it, and we tend to downgrade those. And obviously tumours often occur, you know, towards the apex and towards the base in the transition zone as well. So location can help you. But I agree, the only thing that's really worrying here is probably the diffusion. I think the T2 less so. So I think we would probably keep this as a lower score. I think it is something that if we were not going to biopsy this prostate, we would not biopsy it just because of this lesion. But if we were going to biopsy it because there was another lesion, then you may well then say to target this. Our institution doesn't use PIRADS, and quite a few of the UK institutions don't, and there's a sort of historical sort of reason for that. I think the PIRADS version 2 is absolutely fabulous, and it's a lovely lexicon and primer to allow you to start to report prostate MRI. It gives you a really nice way to hang your visualization of the sequences and to work out a score as to how suspicious or not you think a prostate is. It falls down in several areas, and for us, the biggest area that it falls down is that you should only use it for naive prostates, you know, prior to the initial biopsy. And one of the reasons that we don't use it at UCH is because these sorts of cases form only a small percentage of the cases that we look at. And a lot of our cases are post-ablation cases for follow-up. They're post-radiation cases for follow-up. They are active surveillance cases for follow-up. And you can't use your PIRAD scoring for those. So for us to have a different scoring system for all of the different prostates that we look at was going to be a bit tricky. As I said at the start, we've done prostate reporting for so long. We had instituted our own system prior to PIRADS, and we had drawings, we had lesion scoring well before the PIRADS committee met and went through into version 1 and then version 2. So we've sort of kept to Likert scoring, a 5-point scale based on our probability of where we think our suspicion for tumours. And yes, we involve all of those lexicon things that you get in PIRADS version 2, but it allows us to use it for all of the different prostates that we see. It allows us to use the PSA density, the DRE findings, patient factors, family history, and location, in order to nudge us as to whether we're going to, where we're going to score it. Having said all of that, you know, and the other issue that I have with PIRADS, sorry, you've got me on a topic now, is, you know, the difference between a 4 and a 5 is only size and perhaps a little bit of invasion. Whereas I think with small lesions, sometimes you can be absolutely certain they're tumour. And I would call those a 5, even though they're not 15 millimeters and they don't show any invasion, because I want to convey that if they come back negative at biopsy, or, and we haven't discussed this, the biopsy needs to show something that's giving the MR signal. So obviously one of the confounders in prostate cancer imaging is granulomatous prostatitis. So if I score a 5 and the pathologist says there's lots of, there's prostatitis, significant chronic prostatitis, then that's again something that you wouldn't have to go back and rebiopsy. I probably said too much, Jeremy, but hopefully I've conveyed some of the PIRADS issues.
Claire,
Jeremy, do you mind if I add something as well?
No, absolutely. Go ahead.
So look, I think the PIRAD scoring system is great, and it's really important for centres learning to use MRI to use a universal system that people can understand and follow and apply. But as the centre gets more and more experience, what you'll find people doing is exactly what Richard did, which is use his own judgment from his experience to slightly modify what he thought from the PIRAD scoring system. And actually, if you look at data, when we looked at the precision scans, which are all scored using PIRAD's scoring system, Actually, when we did the quality control centrally, we found that's what a lot of people were doing. So they say they're using pyrides, but technically, if you're modifying it according to your own experience, it's no longer pyrides. It's now LICA when you're using the clinical information and your other judgment.
Yeah. No, that's fantastic
And in
insight.
fact, Jeremy, in your other webinars, Yeli did exactly that. He said, I'm not scoring correctly.
Yes, exactly. Yeah.
Yeah.
I think that's a fantastic insight that you bring, actually, because I think that's true. Richard, would you agree with that?
Oh, yeah, I would say beware the small prostate, beware the asymmetric restricted diffusion, and the focal rounded contrast enhancement.
Yeah.
So Claire, just with going back to this particular case, even using the Likert scale, what would you call it, given what you've seen on those images?
I'm sorry, I can't remember what the PSA density was.
PSA density was 12%, so nice and low. PSA was 4.7, positive family history, but rectal exam benign.
I would probably give it a 2, but I would like to go back and have a really good look at that peripheral zone and make sure that there wasn't a peripheral zone lesion that we'd missed.
Okay. All right. So this patient went on to have a biopsy because he was called PIRADS 3. Veeru, what sort of biopsy would you do? Well, if you did do a biopsy in this patient, do you have an idea of whether you would include template or whether you would just target that lesion? What would you suggest?
So if it was a primary biopsy coming to us, we're considering him for all options, focal, radical treatment. I would definitely do some targeted biopsies to that MRI lesion, and I would probably do some contralateral peripheral zone biopsies as well.
Terrific. Okay, Andrew.
So he had targeted biopsies, and that is grade group 3, high percentage pattern 4, including cribriform architecture, and maximum 8 millimeter in length.
So I guess obviously this is in somewhat contrast to the first case, which was pretty straightforward, and we really wanted to illustrate, just how challenging and nuanced prostate MRI can be. We've got PIRADS 3 or possibly even negative, even factoring in these other issues. I mean, PSA density of 12% is favourable. Even his total PSA is not particularly elevated, and yet he's got a decent amount of grade group 3 in terms of volume. So based on that, and I'll just share my screen for a moment, he had what we would normally do with a grade group 3, and that's have staging with a PSMA PET scan. So I'll just share my screen for a moment. So this is just one slice, obviously, but you can see the avidity there. Hopefully you can see my screen in exactly the same spot, basically, as where we're seeing it at that right apex there of the prostate. So I'll just stop sharing that. But that's what we typically do. I guess we've had the benefit of having PSMA PET availability for several years now. So it really has come into routine practice certainly for higher grade biopsies. So on the strength of that, and certainly no evidence of metastatic disease, he went ahead and had a radical prostatectomy. And Andrew, I think you should have that.
Yeah, and that corresponds beautifully. It's down in the right apex and in the lower part of the these are the axial or transverse sections of the prostate. So just in that lower part of the prostate, it does, interesting, use the term before bilobed, Richard. It does have a bit of a bulge and then a cut in, and that's seen histologically as well. And then this was graded as 4+5. So I know we called it grade group 3 in the original biopsies, but obviously there's a component of pattern 5 that wasn't picked up on those original biopsies.
What do you make of that upgrading?
Well, that's pretty easy to do, because all I've really got to do is undersample, or you've got to do is slightly undersample an area that has some pattern 5, and it doesn't take much for me then to tip over into a grade group 5. All I really need to do, we use tertiary pattern in radical prostatectomy. So if I'm seeing a percentage pattern 5 that's or a grade group, a pattern 5 that's over 5%, then it would change from being a 4+3 tertiary pattern 5 into a grade group 5.
Claire, what's your response?
Did we put that into the transition zone when it's a peripheral zone lesion? Certainly all that apical looks peripheral zone to me, in which case obviously the diffusion is very positive.
Yeah, so I've this kind of straddled, and this is why I'm noted.
Yeah, so I think that was the MR mistake. I mean, obviously, seeing it from London with only those, it looks like it actually was peripheral zone, in which case then the diffusion is very positive. That's certainly all those apical, that definitely looks peripheral to me.
This area here that I'm circling around now, that's definitely transition zone, and then this little bulge out into the peripheral zone. But they were in continuity with each other, so it really is straddling both.
Yeah, but it may well be that it's gone from the peripheral zone into the transition zone, if it's such an aggressive tumor as a 4+5.
Mm.
Yeah, it's just, I think there it may have been a difference in the, I think if we'd seen that there was any peripheral zone diffusion signal like that, we would have definitely called it very positive.
Richard, are you able sorry, Claire. Richard, are you able to just quickly show us the MRIs again on that patient? Have you got that handy?
Maybe show the GAD too, if you could. That would be nice.
So let's put the contrast down here. So the lesion is here.
Okay.
It does enhance the contrast.
Yeah.
But it looks like if you look at the axials, it looks like transition zone. If you look on the sagittals, it's hard to tell. Look on the coronals.
Yeah.
Looks transition zone. So I suppose what I'd like to say is that it's easy to get it. It's easy to overcall in the transition zone. And of the PIRADS 3s that are in the transition zone, about half of them are cancer, in my experience. And so we get it right some of the time. So how I feel is that this is an area of asymmetrical restricted diffusion. I think you should biopsy this, but I'm not sure what it is. That's really what I think.
Yeah.
Veeru, any comments before we go to the next case briefly?
Yeah, if I saw that MRI and I was in theatre about to do a biopsy, I would say the same as Richard. It looks a bit unusual, whether it's in the peripheral zone or the transition zone where there's a bit of uncertainty, but it does look a bit unusual. It stands out to me. I would probably say that would need a biopsy.
Claire, I've just looked at I've got my microscope next to me, looked at the histology. It's the opposite. It's actually transition zone based and aggressive and trickling into the peripheral zone.
Interesting tumour.
So this is just before we move to the final case quickly. I guess the other thing that perhaps this case highlights is, one, we've obviously talked about some of the challenges with MRI, but also where PSMA PET may be useful sometimes if there is equivocation. Now, obviously, you need availability of PSMA PET. It's not available to everybody, but we could see from the image I showed you previously just how well that lit up. It was highly suspicious on the PSMA PET and, of course, was a high-grade cancer. All right, final case. Claire and Veeru, are you happy to indulge us for a few more minutes to knock off this last case? Is that all right?
Definitely.
Sure.
All right. So case 3, while you're getting that organised, Richard, 71-year-old, PSA 5.6, again, positive family history of his father having prostate cancer, rectal exam felt benign. And when we take into account the volume that we're going to see on MRI, his PSA density was 19%, a little bit on the higher side. So he had an MRI on the strength of that PSA. Richard, have you got that there?
Sure. Again, so this is the study. It's a prostate volume of 30 cc, not much in the transition zone. So if I link these ones, it just takes me a sec, sorry.
While you're doing that, Richard, I might just address a question that's come in on the chat. That last case has obviously highlighted a difficult area within prostate MRI. Can we please discuss the low T2 peripheral zone signal and patchy high diffusion weighted imaging signal? Would you call it PIRADS 2 or PIRADS 3?
I'm not sure if I understand the question.
Well, just in terms of the combination of low signal on T2 and patchy and patchy high diffusion weighted imaging signal, would you call that PIRADS 2 or 3? Now, I suppose you called it 3. Is the answer.
Question we've just talked about.
Yep.
Yeah. Yeah. I think it's focal asymmetrical restricted diffusion. I call it 3. But if it's extremely well defined on all planes on T2, I'd probably go back towards a 2.
Okay. All right.
I'm not sure that's the question though.
If there was no focal lesion
In the transition zone?
Yep.
I'd call that a 2.
Okay. All right. Let's.
Okay, so if we go from, again, base to apex, T2 in the top right-hand corner, we can see there is an area of asymmetric restricted diffusion, which is quite relatively subtle here on the axials, dark on the ADC, bright on the high V-value diffusion, which corresponds to this area that's really at the junction of the anterior transition zone, anterior peripheral zone, and anterior fibrous stroma. Interestingly, this is much more obvious on the high V value, the sagittal image. If we go to that, we can see it actually goes from most of the mid prostate. The ADC I've got measured there at 800. So I think that's a PIRADS 4 lesion. But if we go through the peripheral zone, there's nothing on the T2s on either side or on the high V value. Or if I can just bear with me, I'll just show you this is the contrast. There's nothing really on the post-contrast. And if we look at this as the early subtracted images, which are the ones that I use mostly, there's nothing that's really focally enhancing. Maybe a little bit here on the left, which is just a bit of, the ADC just does not get low enough for me to be excited about the left-hand one. So I think this is a single lesion involving the anterior peripheral zone, transition zone junction, or anterior fibrous stroma, and I've called that a 4.
So Richard, the lesion on the left peripheral zone mid, that one that you've got there,
yeah.
Coronally, does it look bigger than that?
Sorry,
it looks like it's focally enhancing to me.
It does. It's very. You can see there. It's very linear.
Is it linear also on the coronal?
So the top left-hand corner is the coronal. Let me just pull these sagittals up so that we've got all the T2s together. And that's it there. It's very linear. But it does enhance with contrast.
Yeah.
And
there's also something on the right on the capsule at about 7 o'clock.
On the T2s?
Yeah, on the GAD, I think.
Okay.
I can't remember quite where it was because I haven't seen the images. So, but it just caught my eye when you put the initial map up. There was something on the right, but you may not be.
I can't convince myself there's something on the right. So it will be revealed in the moment. But this is the.
Okay.
So this is
well,
I could get correlate to that on the axials, on the subtracted images, or on the T2s, or on the high B value.
I must admit, I think that left side, I would definitely probably be a little concerned about.
Yeah.
Yeah.
Yeah. So I suppose there I'm saying it's extremely linear on the T2s, but it does enhance with contrast. So I would call it a 2, but we'll see.
Yeah. You always find those tiny little lesions that you see really well. Yeah. Okay. Let's have a look.
Here, Jeremy, it's a good example of, we don't know what the results are yet, but this may be a potential value for contrast, these small lesions. And if you're using the LICAT scoring system, you may score that as a 3. Perhaps Claire will tell me what she would score it as.
Despite the fact it's not got a diffusion lesion, yes.
And the PIRADS, it wouldn't be scored a 3, it would be scored lower. So if you're using PIRADS, you probably wouldn't biopsy that. If you're using LICAT, you probably would.
So that's, again, you're talking about experience before, but I would say if I see a rounded enhancing lesion on the post-scans, but nothing else, I call that a 3. But it's not PIRADS.
Okay.
So you can see that enhancing on that bottom left picture there, can't you, Richard?
That's this one here.
Bottom left. Yeah. There it is. All right. Well, he went on to have a biopsy, and Andrew can show you that.
So this is where template and target is good. Our left anterior target, which was the initial lesion that we saw, there's quite extensive involvement, up to 10 millimeters in multiple cores, but 3+4, low percentage pattern 4. but we are picking up something in the right mid as well, and the left posterior. Both small though, 1.8 millimeter maximum for both of those grade group 3s.
So we didn't target those other areas. They were just picked up on template because they weren't actually mentioned in the MRI reporting. So based on that biopsy, we went ahead with a radical prostatectomy. And Andrew, perhaps you could show us that.
Go straight to that. Yep.
Yeah.
So this is the pictorial representation. So that large anterior lesion, and then the smaller right-sided, right mid peripheral zone index lesion, and also this lesion here is that left mid lesion. And so 3+4, 30% for that right mid peripheral zone lesion, and 3+4, 20% for the left anterior lesion. So we've seen both of those were graded as grade group 3 on the biopsies, but having a better look at them, we end up kind of downgrading them, but they're still certainly higher than that initial or the larger dominant anterior zone or anterior transition zone lesion.
So we actually found, in other words, that the higher grade, just because there's a little bit more pattern 4, was actually on the right side in the peripheral zone.
I'm not sure we can see that on MR images. Even in retrospect, I don't think we can see that.
And interestingly, I mean, we don't, you say that you can identify that left peripheral zone lesion there, Andrew. You sort of would have expected, given the linearity of that lesion on MRI, that actually it might have been a little larger than that.
Yeah, it's also closer to the base.
So I wonder if that is actual cancer or not. I think the jury's perhaps still out on that. Andrew?
Well, I can tell you it's cancer whether or not it's on the MRI.
Yeah. I'm not sure that's the one that correlates to the MR.
It's only small as well. It's whether or not you would be picking that up.
On the sagittal, though, it looked as if it was pretty longitudinal.
I'll drop the screen and see whether or not Richard wants to bring it back up.
Yeah, do you want let's just review that MRI to finish off the session.
So you can see that. So this is the one that Clare was concerned about here. It goes really from the mid to the base. You can see it here, and there it is on the sagittal. So I'll just play that up a little bit further. It goes up. I'm not sure that's the one that we're seeing. The one looks like on your picture, Andrew. It looks like it's more in the mid prostate rather than the base. So I'm not.
Yeah,
sure.
for me though, the signal's different. So that signal that you've got there, the wedge-shaped bit. I mean, I can't see the scans obviously, but it just looks like there's more signal towards the medial end of it. Yeah. So I totally agree with you. I don't think it's the whole thing. It was just that it's again, it's one of those look at me areas, which is why I would definitely have said to sample it. And I can, yeah. And sometimes, you'll have a tumor and then you'll have the little wedge shape of the gland that just collapses behind it. So, I don't think that's all tumor. I agree. And I don't think the signal's the same right at the base as it looks like there. I don't know. We'll never know, but at least, and I think I would have had both of those as targets. I would have had the right and the left as well as the anterior, I think.
And this patient didn't have a PSMA PET scan, but that might have been the final arbiter in this case, because even the histology hasn't quite necessarily given us a clear answer. Veeru, any final comments from you before we wind up?
Maybe I'll leave you with a controversial point to consider, and it's really, is there a difference between visible and non-visible 3+4 or grade group 2 disease? And I think the jury is out there, but there is some evidence, molecular studies which look at genes of aggressivity associated with metastasis, which are upregulated in visible but not non-visible 3+4. And the other thing is there is some clinical data. We've got some clinical data from our active surveillance cohort. And when you look at how the patients with visible 3+4 do compared to those with non-visible 3+4, actually those with non-visible 3+4 fare similarly to the 3+3s. Yeah. So, and you can see that in the paper in European Urology, Stavronidis is a nice Kaplan-Meier which shows that really clearly. So I think it's just food for thought, something to think about. How do we, this disease that we're missing on MR in some cases, does it carry the same clinical significance?
Yeah.
I'll leave you with that one.
I'm glad you brought that up. It kind of seems to argue against doing template biopsies, if that's the case.
I'm pretty sure Mark Emberton would argue that that is the rationale for some of targeted only biopsies, targeted MR visible lesion treatment based approaches.
Thanks, Veeru. Well, look, we have gone a little over time, so I'm mindful of everyone else's time. So I would like to thank everybody, and we'll wind it up there. Thank you to all of the people who have beamed in from all over the world. I hope you found it useful. I'm sure you have. I'd like to especially thank our panelists for taking up their Saturday morning. Clare and Veeru, thank you so much for joining us. And for everyone else out there, don't forget to have a look at the website that Veeru has mentioned to you if you want to sign up to the UCL workshop that's coming up later this month, 25th and 26th, I think, of September.
24th and 25th.
Sorry, 24th and 25th. Just a reminder also that we'll be posting this webinar online in a few days' time. So if you haven't been able to see all of it, or if you've got colleagues who you think might find it useful, then go to the MRI Pro website, just mripro.io, and you'll be able to see it there. Also, just to remind you that we're now offering the monthly subscriptions in addition to the annual subscription, which you might find a lot more cost effective depending on how fast you want to go through the cases. And finally, shortly, we'll be sending out a survey to all attendees to provide us with your feedback. If you feel like doing that, we'd love to also learn from you as to how we can best make these webinars as useful as possible, as well as the MRI Pro program itself. So thanks once again to everybody, and stay safe. We'll see you next time.